Hi, welcome to DSL's roundtable discussion on Genomic Insight and Opus23 Explorer. With us today is Dr. David Brady, our Chief Medical Officer. He's our clinical and scientific advisor, kind of all things precision medicine, and an invaluable part of our leadership team at DSL. And we're also pleased to have Dr. Ralph Esposito, medical consultants, research analysts, and experts in nutrigenomics and the Opus23 platform, having served under Dr. Peter D'Adamo. And so we have them today. And Dr. Brady, if you would just take us through the Opus23 Explorer and Genomic Insight application.
Thank you, Jeff, and hello, everybody. And what we wanted to do today is have kind of an informal discussion, kind of a roundtable presentation, if you will, and particularly wanted this to be helpful for people who are first approaching using Genomic Insights and the back-end informatics platform, which is Opus23 Explorer. There may be some listeners who may be familiar with Opus23 Pro, which is a slightly different version of the Opus platform, which was coded by Dr. Peter D'Adamo and various people who work with him. With that said, Ralph, I'll probably turn it to you first. And what I want you to do, since you're an expert in trying to mash up this kind of data and make heads or tails of it, I want you to give a little overview of how someone would start trying to use the Opus23 Explorer platform once they got their data back from Diagnostic Solutions when they ran a Genomic Insights genetic test.
Absolutely, and thank you so much, guys. I really do think that, before I begin, I just want to say that this program, the power with it is pretty much unlimited. So what I will be giving you is a view on how somebody who is experienced as myself in using the program, how I would go about basically navigating each part of it. I think before anybody wants to go into this program and tries to make any conclusions or dig into anything, the one thing that I certainly emphasize to all practitioners and even to patients who are getting the report is this data, this information is all within the context of your personal medical history, past medical history, and family history. So the one thing that each practitioner must do before going into this is actually get that information from the patient or client, because that will drive and determine what areas you want to address and what areas you're going to focus on. Just because, as we know as clinicians, family history is very strong, and it does give us more information as to things that we have not been able to measure yet. However, with the Opus23 Explorer, we have tangible, measurable data that we can use, and using that in combination with the family history, personal history, supplements, etc., you will be able to focus and fine-tune your approach much better than just going in with this blindly and trying to determine somebody's health from the data. Whereas I think getting somebody's health first with the data then gives you much better insight. So with that said, when you get the information from the patient or the client, the first thing that would come up is obviously you will get to load the patient, and you will pick your client from the list, and that's what we've done for you so far. So we have a sample patient here, and the first thing that will come up is your report wizard. So this is different than Opus23 Pro. This is actually a auto curation, a autopilot function that allows you to determine what areas you would like to assess, and then will create a report based on the program's algorithms that would dictate which SNPs and algorithms are most pertinent to that patient. So basically allows a practitioner to go in and say, I want to find out, what is the endocrine and cognition issues with my patient, because they have a history of, Alzheimer's and perhaps hypothyroidism, or just Alzheimer's can be both of those together. So you would go in and try to assess those things, and these are the two categories that you would pick. Now, for experienced practitioners, this might be too simple, but I think for a lot of beginners or people who are even just learning about genomics, this is going to not only provide them the insight as to where to start or what information that they can gain from this, but it will teach them and say, hey, when you go through the program, I can see that the auto curation curated, ApoE several times. What's so important about ApoE? And then you actually learn from it. So,
Hey, Ralph, I'm going to interject here, and I'll do
sure.
that periodically just to ask some questions from the perspective of a clinician who may be listening. So this report wizard, like you said, is sort of an autopilot mode for people who may not have a tremendous amount of experience like those who may be using Opus Pro when they're going in and doing their own individualized curation. This provides the clinician a way to basically drill down on what we consider a category of their SNPs or their genetic information. And as you said, it needs to be contextualized with what their presenting complaint was, maybe what their symptoms are, what their family history is, what their other types of lab tests may suggest. So the report wizard is sort of like driving the car in automatic, where you're going to show a little bit later, driving the car stick shift, where you can kind of be more actively involved in every little nuance of what's selected to be analyzed. But on this screen here, where you show these various boxes are shown, can you go over, like, they're clickable boxes, correct? And you can click them. You can click one or you can click multiple boxes. I think there's a limit on the number of boxes that can be clicked in one pass. But then can you sort of explain that, and then those drop down sort of choices down below that would relate to that the report that's generated from those categories for that specific patient's data?
Absolutely. So each category, each box here is a particular area of health that will, some of these will give you certain SNPs based on the disease process or the syndrome or the disorder. Some of these may overlap. You may see some type of, you might see ApoE in both, cardiometabolic and cognition, right? So you might see very similar SNPs show up, but you can select which ones you would like to add. And I believe the maximum is 3. And the reason for that is this program can be overwhelming if you give patients too much data. So we keep it to 3 because that seems to be like the happy medium where you don't lose somebody's attendance or presence during the visit.
But keep in mind, the data set's always there, so you can always come back later and curate a report with other categories. Like, you can kind of take stuff in steps, right? So you don't overwhelm the person, and the client report isn't so arduously long that their eyes just glaze over. So it's kind of better to chunk it up a little bit. So that's why that feature was built like that.
Absolutely. I actually think that's a better approach. And, some practitioners might get overwhelmed. And if you only have 45 minutes with a patient or an hour with a patient, sometimes doing 3 can be overwhelming. So if you just wanted to do an endocrine, and this would include things like, thyroid dysfunction and metabolic syndrome, and sometimes it might even include some sex hormones, right? So that would be something that you would want to take a look at. Anti-aging, this has to do with a lot of, again, might be similar to cognition, but we're looking at different things like antioxidants here. Obviously, methylation is pretty straightforward. We're looking at the MTHFR and other various algorithms and SNPs that coexist with that. So one very important thing that this has carried over from the Opus Pro is that it includes algorithms. So we don't look at single SNPs only. We look at how multiple SNPs together communicate and in a epistatic relationship, which is basically the interaction between various genes and gene products, and how that can impact outcome. So you will see that in methylation very clearly. Detoxification, again, we'll talk to you about, phase 1, phase 2 detoxification. Inflammation, again, we'll talk about different types of anti-inflammatory agents that can be used and different SNPs that might be up or down regulated during inflammation. Energy and metabolism will then give you more information as to things that might be having to do with mitochondrial dysfunction, or even energy in terms of how you partition fuels. Structural, obviously, will have to do a lot of musculoskeletal conditions, may even give you some advice as to what types of exercise might be best or worst for the patient. Cognition certainly is neurocognitive issues such as ApoE and TOM40 and et cetera, which will help you, it might include things like COMT, the worrier versus the warrior type of quote unquote type of mentality. And then lastly, you can even choose androgen, estrogen, or cardiometabolic. Each one of these, obviously, estrogen genomics will give you basically estrogen metabolism. Androgen genomics will give you things like androgen receptors and testosterone. And then, don't take this for granted. Just because androgen genomics has the male arrow here or the male sign here doesn't necessarily mean it's only for men. Certainly can be used for women as well, but you'll see that this will include more prostate stuff and it may not be applicable. So just be very careful when you choose this. I would probably just keep this off if it's a female patient. And then obviously cardiometabolic will involve a lot of, CETP, and obviously may also include other things that include fuel partitioning. So each one of these will have its own particular uniqueness, but some of it may overlap. And if you just want to do one, then you certainly can do just one, which oftentimes I do recommend to newer practitioners. As we go down here, you can see different dials that you could turn on or off. So the network maps, this will tell you, and we'll go into this on the left-hand side where you'll see the network maps in much more detail, but this will tell you, do you want to include the network maps for cardiometabolic? And it'll pull from the program any network map. So a network map is basically a biochemical pathway, and it will, in live form, tell you where this individual SNPs lie within this map and whether they're decrease in function or have less function, how many SNPs are present there. So instead of just looking at a biochemistry pathway, it tells you this is the biochemistry pathway, and then we'll tell you what is and it will implement and plug in the patient's SNPs to see where there might be some issues in that pathway. So that you can include or not. Then we introduce explanatory text. I highly recommend that you include this. This is basically a genomics for dummies type of version where it explains things very, very simply. What genomics are, what is a SNP, what is a mutation, etc. for the client or the patient, which saves you a ton of time. And I would just tell people always include this, because you can send them home with this and say, hey, read this. Everything I'm telling you is in here. And then we can talk about this later. Non-risk SNP genotypes, that will tell you whether an algorithm is true or false. So if there's SNPs that might show benefit or SNPs that have shown no benefit or no impact on the patient's health, it will include them. But sometimes the patients want to know if there's something good in there. So this program is not only designed to assess dysfunction, but it's used to assess risk. And if you're assessing,
we also made that addition, Ralph, because some clinicians also, let's say they run the methylation category, they're going to look for those, there's many more than they're used to looking at, they'll find out in this program, but they're going to look for those major SNPs that they're used to seeing. And if you don't have this checked, if one of those major SNPs that they might be looking for has no risk associated with it, where the alleles that come up are not in a risky pattern, if you don't check that, they won't show at all. So now it'll show that there's no risk. So sometimes patients also want to know, well, what about this specific SNP? What is my status? And they want to see it even if there's no risk in their pattern.
Right, exactly. And you can, as a practitioner, you can go into the program and look that up yourself, but it's good to have that on the paper for them. Obviously, right. It's a little bit more proof for them. Next, we have the high value agents, and these are the agents here that will tell you which nutraceuticals or nutrients or even hormones that might have most impact for this individual. And what it does is the program will automatically curate and will decide based on the data in this individual's particular SNP patterns what agents. So when we say agents, this can be vitamins, it could be minerals, it could be herbs, it can even be lifestyle interventions like meditation, or even some type of dietary interventions like low fat, high fat type of diets. And it'll curate that and it'll give you a panel as to how high or how low or how much of an amplitude this might have on the patient's health. So it allows you as a practitioner to decide, am I giving somebody this? If not, is this really important? Or if I am not giving them this, maybe I might want to consider it. And on top of that, which I'll also include on the bottom here, we can actually give you recommendations for any particular designs for health products that will be based on the high value agents. So for example, if you have a product that, if the high value agent is vitamin E or even vitamin C, that's a great recommendation. But again, the quality of the product and the things that we're putting out there that can have a therapeutic impact can vary based on, they could get something from the local pharmacy or they can really get a good quality product. And this just makes it easier to implement and improve compliancy with the patient to make sure that they're doing what you want them to do.
So the client-side report will always give generic information on the agents, the nutrient, the botanical, or so forth. But there is an option, and it's an option. You do not have to include it, that if you want to know very specific formulary products to use that might meet all of those requirements that this patient, we're suggesting you give them in the most efficient way. We worked with our collaborator in the nutraceutical space, Designs for Health, to basically integrate their product line in. Once again, you can include it or choose not to.
Right. And then lastly, and actually this is one of my most favorite parts of the program, is that the possible drug interactions, this is the pharmacogenomics. So if your patient is or is not on a medication, they will receive the information based on their SNPs, whether a particular medication or drug will or will not be effective, whether increase function, decrease function, or they might have adverse reactions, or perhaps they may not need as high of a dose. So this is really important. And the one thing to lay across to the patient is that these things will not change. This is what you are born with, and this is the data that we have. The only way that it will change is if we obtain more data. So you can say, if you're not taking this medication now, but in 5 years it's a potential medication for you, then this is something that you want to pay attention to, and that'll be included in the report.
And that's an interesting point, Ralph, because what clinicians need to understand with this kind of testing is that, as you said, it doesn't change. I mean, the genes don't change. We can change how we play them, right? We can change the outcome by changing their lifestyle and the agents and the medications or what have you, but the data is not going to change. Now, there may be a time when the chips will look at even more data, but right now they look at so much more than we can even deal with. It's pretty astounding, but this data set will remain. So the clinician doesn't have to retest this specific data ever. You can come back to the program though and access the data and ask it different questions and go into different areas depending on what may emerge in the patient in the future. So it's really quite a useful set of data to be sitting there that you can come back and use this system to basically parse through it, mine through it, and try to get answers even in the future.
Right, and on top of that, I would say this is an excellent way for the patient and even yourself to communicate with another patient's prescribing doctor if you're not prescribing it. So you can show them, here's the data showing me, amlodipine is having is explaining the symptoms for my patient, and you can communicate this with other practitioners, and it's like the proof is in the pudding. Well, you see it, patient showing the symptoms, now let's make some changes here. So I think that's another advantage that can be used.
Ralph, why don't you leave all the check boxes on the bottom yes, okay, for
Sure.
right now. And keep in mind, the more you have yes, the longer the client-side report gets. So if you're trying to shorten up the client-side report, you need to consider which one of these areas you may delete. But for right now, we're going to leave them all active. Why don't you hit the methylation category only, just to keep it simple. And since most clinicians, when they're dealing with SNPs and genomics, they probably see more and know more and have heard more about methylation than anything. And you can argue whether that's a good thing or not. But why don't you go ahead and run the report wizard in that scenario? And maybe scroll through the client-side report. And this client-side report, this is what you now can save as a PDF, or you can print and review with the patient.
Exactly. So once you actually click the report wizard, it'll tell you what Opus is, and then it tells you everything that we're going to be focusing on here is methylation. And this is the basic language that most patients will not understand if you just jump into the SNP and genomic data. But this introduction will give you and the patient information as to what is a SNP, what is an algorithm, what is a mutation, what are we looking at here, and it puts it in very simple terms. So again, this is also in the Pro, but again, when we are trying to explain things to patients, we want to make it as simple as possible. And as I mentioned earlier, it saves you a lot of time. So you can send them home with this and say, hey, everything I'm telling you in here, everything I'm telling you is already in here, but here's the 2-second version, but you have the 15-minute read right here.
So this is the check down box that says introductory descriptive
Correct.
information. I forget how it exactly phrased that. Right. Okay.
Exactly right. So
go ahead
as you
and
move
scroll
down,
through that and show some of the elements of that. I know it's all typed now, but it does get into some more graphic things to show how the data will be reported here in the client-side report with the different color bars and so forth.
right, so this part will tell you and tell the client how you're going to be reading the report. So we see here, one thing that's really important that I want to emphasize is when people say risk, this is the risk allele. It does not mean if they are at risk. And the reason why we use that word risk allele is just because that's what's used in the literature. And again, if we're going to be talking about genomics, I think it's important that we all keep the same language. And so when somebody sees risk, it's just telling you what is the, or another way you can say, this is the interest allele. This is the allele that we look at that might lead to either a benefit, which is a B and it's green, or a risk, which is the orange. And then you can see here the patient is heterozygous. They have the A and the C allele, right? So that will provide benefit, and you can see here it'll show the magnitude, right? So that's a benefit for them. Whereas this one here, which is a risk allele, it's A, it's a risk. They have homozygous for the risk allele, and then it'll tell you exactly what the magnitude is. And this is how you will read the report. Typically, green is good, orange is bad. Now, orange, the heterozygous, is not always bad, but you have to take that and understand what it is per SNP. So this will tell you how to read the report. And then moving down, you see the selected agents will tell you, what agents might be most influential here, what has most impact on these related SNPs or algorithms. And then again, the indicated products, which basically tells you these are the agents. Now, this is how you use it in real life.
And this is just defining the symbols. There's nothing listed there for selected agents or products because this is just this descriptive area. You'll see what that looks like as we scroll down into the actual results on this patient's data specific to their methylation related information.
Exactly. So this is basically your legend. As you move down, you see the multi-SNP macros. And again, this is what makes Opus23 Explorer very unique and different from many other programs. And this is why many people misunderstand genomics is macros are basically algorithms. And an algorithm is if A and B, then C and D, right? So if you have SNP A and you have SNP B, then that may indicate, condition C or condition D. And that's exactly how our body works. And this is why we don't see, frank deficiencies or frank dysfunctions when somebody has one MTHFR mutation, because I'm sure many of you have been through a patient and they have two homozygous risk alleles for the both MTHFR 677 and 1298. And you say, well, why isn't this patient showing symptoms? And because there's other things that must be taken into consideration. And that's exactly what this is doing for you. And so you'll see a lot more of this into the program. And this is what is kind of, I would say the bread and butter for most practitioners utilizing the program. As you move down, it'll then give you a map or a 10,000 foot view as to what are the homocysteine genomics, what are we going to be looking at? And then as far as this goes out in the pie graph, it'll tell you, well, they have the homozygous recessive allele, right? And then they have some heterozygous, and then they have some here which are basically null, which may show either no benefits or are neutral. And the more SNPs you see here, you can see, or the farther it comes out, the more SNPs that this individual may have. Now, don't take this to mean that if the orange is, at the tip, that's the most influential. That is just how it's been organized, as you can see here. And again, you can see here the green is at the bottom. Just because it's green here doesn't mean it's less important than the orange up here, the yellow up here. It's just telling you these are the amount of SNPs, and that's how it's been organized. But you can see here there's much more SNPs for CBS than there are for MAT1A, and that's what this is presenting here. But as you go through it, it'll tell you everything, and it'll educate you and the practitioner and the patient as to what is homocysteine, what are we looking at, why are these things important.
And Ralph, when you hit on the radial diagram on those spokes there was a power factor. Can you just mention what the number and the PF means?
Sure. So the power factor is basically an algorithm or an equation that the program has used, which will determine how important or how influential are these sets of SNPs in the patient's health, or how much they help or impact a particular condition or syndrome. And this power factor, again, is an equation which is determined mostly by the data or the literature. So if there's and when I say that mostly by the data in the literature, I mean how many in vitro, in vivo, animal, human trials are there? And what we can see here is that there's a lot more studies on CBS than there would be on, MAT1A. You can see the power factor is much less. And this is basically telling you, and I'm sorry, it divides it per whether it's homozygous, heterozygous, or a risk or not, right? So it's telling you here that the heterozygous for the CBS, the power factor is 6, and then it'll tell you that it's 70 for the neutral, right? So what this is really just telling you is how much data is there and how much do we know about it, which can give you an indication as to how important is this supported by the research and how confident can I be that by impacting or influencing this SNP will have an impact or have an outcome impacting the patient's health as in an overall basis.
Great, thank you.
Moving down, we are then getting into each individual SNP, and we can go through each and every single one. But what we're seeing
let's just center on, maybe pick one.
Yeah, let's go with MTHFR.
Maybe pick the two biggies.
Yeah. So let's look at MTHFR, and obviously this is the education part. So this part here will educate the patient and the practitioner as to what MTHFR is and what are we looking at. And then it gives you an idea of a few bullet points. We're looking at 677C and 1298A, right? And what we're looking at is what are these SNPs and how do they influence our health? So a very simple explanation as to what they do in the body. And then it tells you what are the outcomes. Now, very interestingly, many people will talk about MTHFR and they only talk about 2 SNPs here. But again, we're reporting multiple SNPs. And you can then, this is our legend, and it tells you what is the risk, the type, what is the patient, and then it tells you the magnitude and any keywords that are associated there. So this is really just an informative tool for the client and the practitioner. And as you can see here, it'll tell you based on the grand scheme of things, how many are homozygous and how many are heterozygous, and of course the neutral, the null. And we'll see, this will give you an indication as to how much should I be paying attention to this. It does not tell you.
Oh, I'm sorry. Down in the SNP numbers, the RSID numbers,
yes.
It doesn't list, 677, C or any of that. So up above, it does make those references for you, I believe, in the bottom of the top paragraph, right?
Yes, it does. So you can refer.
677T is it shows the RSID number there, which is the first one on the list. So just to point that out, because I've had some clinicians ask me some questions on that. They're not quite connecting the dots between the two because they're used to seeing these very sort of simplistic, reports, like if you run a methyl genomics panel with a certain lab or you run an estrogenomics, it's just static information on only a few SNPs, where this is dealing with a much larger palette of SNPs, and then it's actually using back-end informatics, AI, and all that to kind of parse through it and figure it all out. So this is a lot more information than clinicians are used to seeing, and although the program does a great job at curating it and boiling it down and trying to deliver to you what's important, it still is a bit more information to process, even when you're running the report wizard, than they may be used to from other types of older ways of reporting this stuff.
Absolutely. And I think one thing that we should pay attention to here is that this program, other programs, they'll give you the information, but we're trying to bring your education up to another level and allow you to truly, if you truly understand genomics, you will be able to get the most out of this program rather than just being told, this is the report, this is the outcome, do this. And of course, we do that here, and we give you all of the basic foundation to know what can be done for your patient. But learning the program and learning from this information here will allow you to master the material more than anybody else could probably understand, and that'll make you a better practitioner, and the patient obviously will benefit from that as well.
That's a great point, and Peter makes that point a lot, that when you use Opus, It's not just using it to get information to do the right thing for your patient, but it's actually a master course in nutrigenomics as you're using it. And that's the best way to learn something, right? As you're using it on the job, as you're applying it. So I would just encourage clinicians who are new to using it to, use clinical and technical support, just, run through it. You kind of get very used to it very quickly as you use it. Just don't be daunted or intimidated by it in the beginning, just like when you first saw your first organic acid report, right? It's a lot of long chemical names, but now people are used to them. Same thing with this.
Exactly, and you will get better with it with time. And then here we have the owl figure, which is Mr. Smart Owl. And again, we'll explain what a nucleotide is, what is a mutation, what is a polymorphism. It takes all of the work out for you. All you have to do is say, if you don't understand what I'm saying, this is what I mean. And if you forget, go back here and it's all explained for you. And then again, this is repeated for any SNP that is responsible or involved in the methylation of the B12 folic acid cycle. And again, one thing that seems to get ignored or overlooked is MTRR, which is a reductase, and that's with the recycling of methylfolate and methyl B12, right? So when we look at just MTHFR, we might see normal function, but if there's an issue with MTRR, which again is the recycling of B12 and methylfolate, you can get a better understanding as to, I'm not seeing a lot of issues up here in this MTHFR, but maybe down here in the MTRR, that's where the issues are coming along. And again, allows you to put things more into context. And just like the MTHFR, we see each SNP, the risk, the type, the patient's outcome, and what the magnitude might be. Again, moving down, this will be shown for every individual SNP. Now we get to really I think what I call the meat and potatoes of the whole program, and makes me really excited to show this program to other people, especially to patients as well, is you see here when we talk about algorithms, we're not just talking about MTHFR, we're also looking at CBS. And if you understand biochemistry, you certainly understand why CBS is responsible in the methylation cycle and getting rid of homocysteine, cystathionine beta synthase. But what this program, what Opus23 Explorer will do, is it gives you an exact amount of enzyme activity that has been reduced based on these two SNPs that are the major MTHFR SNPs, which also takes into consideration CBS. And because obviously they're all connected, and it'll tell you there's about an 8 to 10% reduced enzyme activity. The way I would look at this is I would say you're functioning at about 90 to 92%. So perhaps MTHFR is not the holy grail or the culprit of what's actually ailing you. And then we have different therapeutics as P5P, which has an impact on CBS, right? So you may know this as a clinician, but now we can see that the program is actually telling you, based on artificial intelligence, you might want to add P5P because it can help support these levels based on the data that is provided and the SNPs that are here, which are listed. And then again, this is also telling you other SNPs. This is what we were talking about earlier as other issues that might be informative to the patient to kind of reduce their anxiety, which basically says, these are false, and very important that you point out that this is false, that these are not influencing the patient. So they don't typically have MTHFR polymorphism impacting homocysteine, and they don't have issues with biopterin. And we know that those are two major impacts that can impact homocysteine levels. Basically, look elsewhere for elevated homocysteine levels. And then as you move down, these are the network maps. And the network maps, again, as I mentioned earlier, put the patient's SNP data in real life. And it plugs it into this program. And as you can see here, MTRR, where I was discussing earlier, might be something that you want to pay attention to because it is having an issue with the tetrahydrofolate recycling. But again, you can look at this and you'll see that it's partially orange, which would be the homozygous, and then it's largely or mostly homozygous recessive, and then you see some heterozygous, and then you see a lot of null. Now, this doesn't tell you whether it's good or bad. It doesn't tell you, should you be impacting this? But looking at this, you can see, how many SNPs are impacting this? Is this something that might be improved if I can support them therapeutically?
So would it be correct that when you look at a network map, your eye should probably be first drawn to the boxes that have the most orange filling them, or is that incorrect?
Yes, I would agree with that, but I also would not ignore the others. And you really have to take this as this is where the art of genomics comes into play. And you have to see, well, where in here do I think I can have the most influence? And that's where I would also look, because you can look, at MTHFR, and you can look at, the beginning of the cycle with FOLH1, and you can see, well, these are things that I can have an impact on. And then I would look at and say, okay, of those, which ones can have might be impaired by function, and that's where I would point my eye to. I probably would not be looking at many of the boxes with the gray, because either we don't have enough data there, or there's really not much that we can be doing there. And then please pay in mind that the cofactors are also involved. So you'll see B6 located here. You see riboflavin down here by MTHFR. Again, everything is within context, and it's telling you everything in a real life for this individual patient. As we discussed earlier, we look at the natural products, and then again, these are the agents that have most influence, and this is based on the data within the program and how many genes are hit, how many PubMed hits are there showing you that this particular agent is going to have an impact on most of these genes. And we can see that Betine or TMG, it might be something that's really helpful. And why would that be important? Well, it might be higher than the B12 because they don't have a very significant MTHFR issues, but perhaps there's other ways that you might be able to get rid of their homocysteine, and TMG is a way to do that. Now, you know that as a clinician, as a practitioner, but now the program is telling you, pay more attention to Betine or TMG rather than the cobalamin.
Interesting, those indication value bars, it's so impactful or high for betaine and for folate that it actually spills over into the, so it's not two different separate bars, it's actually a continuation of the first one, is that correct?
Yes, that's right.
Okay, so a clinician might look at this and go, well, geez, I can't give them all this stuff. Well, the program isn't telling you to give the patient everything that's listed here. It's listing everything that's out in the medical data, whether in PubMed or the metadata sets or whatever it may be, that may be germane for this patient in some way, shape, or form, but this is where the clinician comes in. You have to contextualize it and kind of triage it and pick, well, of all these things, which are maybe the 3 that are most impactful or the 4 that are most impactful, and make a wise decision based on that information.
Exactly. And I want to that point, David, I want to say, I do get a lot of comments from practitioners and say, well, why would I ever give folic acid? Why would I ever give cobalamin? Why not hydroxy? Why not methylcobalamin? And I would agree. And I would say, yeah, that might be a better option. But if we're going to be precise in what we do, right, and precision medicine is, and the focus of this program is to be evidence and research based, this is what is in the literature. Now, that does not mean that folic acid is better than methylfolate supplementation. What it is telling you is that in the literature, this is what we have, and it is at the mercy and at the limitation of what the literature provides. Now, I hope and I wish in the next 5, 10, 15 years, we are doing more research with methylcobalamin or hydroxycobalamin or folinic acid. And if that research is there, it will show up. But don't think that this program is outdated and it's still recommending folic acid. No, it's actually the literature is a little bit outdated, and we're providing you with the information. This is where the art of the medicine comes into play.
Well, plus, if you look at something like B12 and it says cobalamin, technically that could be a paper that used methylcobalamin or adenosylcobalamin or hydroxycobalamin, correct?
Right.
I mean, it's all cobalamin. Right. And in
Correct.
fact, with B12 or cobalamin, it's a different topic, but it's agnostic to it because it cleaves off the ligand when it pulls it into the cell. It's different than folate, which is a big misnomer in the clinical realm, but that's a story for another day. But you're right. I mean, it's going strictly by what the literature says.
Right. And I want that to be clear, because if you're going to have conversations with other practitioners who may not be as educated, you can tell them, I'm not arguing with you. This is the literature. This is what the research shows. And as you move down, you'll see that those agents are going to be listed here. And again, it'll just give them a brief indication of what it can do and what might be helpful for them based on the agents that are listed above.
And just to let everyone know, if you pick to get information on the product specific indications from Designs for Health, all of the different ingredients from these various products, and many of them are formulary products that may have 4, 6, or 8 ingredients or what have you. They're all coded into the program, so it will strategize and try to pick the right or the best formulary product to cover the most ground or the most agents with the least number of pills, basically. So it's trying to up your game in relation to efficiency. But once again, it doesn't mean you should take every one of these products listed. It means that these are things to consider and pick from, and that you'd have to make your best call on how far you want to go in supporting their methylation genomics, because you may have other fish to fry on this patient as well, or maybe this may be the big thing that you want to deal with. So the scenario may change patient to patient, scenario to scenario.
Exactly, and I would say, just to piggyback off of that, something is only as effective as it's utilized, and so basically this will allow you to identify where can I get the most bang for my buck, and which will improve patient compliancy, which is another strength of the program, is where do I focus to get this patient to feel better quicker, and then they buy in, and now compliancy increases.
Now, before we leave Report Wizard, I just wanted to point out that if you pick a certain category, such as, we picked methylation, the natural agents, so the vitamins, the minerals, the botanicals, the lifestyle changes, and or the product-specific information would be specific to that person's genomic information or SNP patterns and so forth related to that specific category. So let's say you pick 2 categories. You pick methylation and cardiogenomics. It's actually going to make these recommendations based on the combination of the data. If you run information in Opus23 Explorer without picking any category, it's looking at the totality of their data. So it actually is smart, and it changes the information it feeds you on what kind of interventions you would make based on what selection criteria you make, which means which category you're picking. What are you trying to center on? So with that being said, Ralph, why don't you go out of the client-side report after you want to cover drug reactions. I'm sorry, I forgot about that.
I just want to show this.
Right.
This is exactly what I was mentioning earlier. Shows you all the drug reactions. Pretty self-explanatory, but for future reference, if you wanted to use an amitriptyline, those with this genotype have a poorer metabolizers. Therefore, they metabolize it less. Therefore, it might have an improvement function, or it just tells you to be careful with that particular medication.
Right, and you may pick to include this data on the report or not on that original drop-down menu. A lot of patients I find like to see this. They can get overwhelmed by it at some point, but many times they do like to have this information and just keep it in case, hey, their primary care doc wants to give them an antibiotic and they look on the list and it says, well, that's likely to cause diarrhea in your genotype. So they'd say, hey, give me a different one. So they like that. But when we're done here, let's go out of the client-side report because we're getting short on time, and maybe just spend about 5 or 10 minutes most pointing to some of these functions that were automated or embedded when you actually use the report wizard, but maybe show those different categories along the left real quick, and how you can search any SNP or any disease or any category using SNP Navigator and hone in your specific search.
Great. So on the SNP Navigator, I will typically use this as the search engine for the whole program. And if I want to find something that I'm not really sure where to look, but I know I want to deal with, Alzheimer's, then I'll type in, Alzheimer's, and it'll bring up everything that's involved with Alzheimer's disease. And so this is basically, it'll find everything for you, and then you decide how you want to utilize it. So then it shows you the gene, it'll show you the SNP, it'll give you any specifics about it. So a down arrow typically implies decrease in function. Again, risk allele, type, as we discussed before, and what is the effect and how the keywords are. So you can see here, this client did you want to mention something, David?
Well, yeah, I was just saying that when you do it this way, you don't have the report wizard pulling all the stuff together for you and deciding what's going to be on the ultimate report for the patient, or what we call the client-side report. So if you search this like you did, Ralph, with Alzheimer's, and you find some SNPs or genetic information that's of concern to you, you'd have to click it over on the left where it says curate, right? And then that would be attached to the output of the patient's report.
Exactly right. So you would click on it and it would add it to the report. And then it'll bring you back to where you were, and then you would search and figure out where you're going to address again. And one thing that I want to, am I spelling? Here we go.
Yeah, there you go.
There we go. So as you bring it up again, you can even click on a particular gene, and it'll tell you, and it'll give you that information. It'll simplify.
Yeah, this is cool information. This is the life lesson again, right? The master course. So, and I'm glad you did that. You can click on, everything's clickable. You can click on any gene, any SNP. When it gives you, references, you can click on the references and it'll send you right to PubMed. So maybe you can show that, like if it's using a piece of data to make an inference, then you can click on it and go right to PubMed.
Exactly. So you can even go down to an agonist or an antagonist. You click on the PubMed article and then it pulls it up right for you. And it says, hey, this is the article that's showing polycolsonol's impact, CETP. And again, the proof is in the pudding. The literature right here supports that. And that's where we're getting a lot of these reports, the power factors from magnitude, and then what agents are most effective. So that's how I would utilize the SNP navigator. And then you could parse it by, what is the patient, what is the effect? You can use that effects. I want to look for things that are down regulating, and then you can just see as many as you'd like, and just parse it out.
So the default list, the way it's triaged when you just go to SNP Navigator, is things that have the highest magnitude of impact and the most likely to be causing issues, right? So it's sort of triaging it for you. Right?
Exactly right. So it says, hey, look at this. But if you want to look at other stuff, please feel free to go ahead. So you can see here magnitude, but again, the patient does not, so COMT, it has a high magnitude, but the patient does not have the risk alleles, so I would completely not pay attention to it for that particular SNP, right? That particular, because there's several COMT SNPs. So that's really pretty much the SNP navigator. Looking at the network mappings, this is the biochemical pathways as to everything that we're looking at. So even if you want to look at estrogen metabolism, it takes the person's data, parses it, puts it into the maps, and says, okay, these are where issues are going to be. These are areas that I want to pay attention to. And this is a really good way for you to combine the real life data, like the organic acids, or or metabolites, or even microbiome data, and you can look and say, hey, this person might have beta glucuronidase issues due to their microbiome, and I'm seeing that they have issues in cytochrome 1A1. Perhaps there's issues in their 2-methoxy metabolism, or their metabolism of the estrone to 2-methoxy. So
can you go back to the? Oh, I'm sorry. Go ahead, Ralph. I'm sorry.
No, and I'm just saying this allows you to put multiple different tests together.
So go back to network maps. So this gives an interesting palette of categories here. It's almost like before the utility was built into the program of the report wizard, this was almost like a categorical kind of thing to pick from and be able to look through different areas of critical metabolism or biochemistry, if you will, by using either network maps or syndrome templates, which you can show in a minute. So you can still choose to do it that way if you want, because there's certainly issues of metabolism and biochemistry and medical risk that don't fall into one of those discrete categories in the report wizard.
Right, exactly. And again, this is a great way to learn. Additionally, because phase 1 and phase 2 detoxification, is not always explained properly. So then again, it'll teach you what exactly that is. And you can even click on the gene here and say, okay, why is this all orange? Well, there's one SNP there and it's recessive. Oh, okay, now I know what this is. This is a glutamate cysteine ligase. And what does it do? This is the practitioner explanation. Then it breaks it down to what the patient might be able to see. You can see it's one sentence. And then you can move down and say, okay, how can I have an impact on this all? Maybe I want to give them, some vitamin B7, some biotin, that might improve function here. And then you have the literature there. So again, you can access this information, the data, via multiple different applications within Opus Explorer. I want to jump to the macros because I really think that this is the one of the most important things of the program. I think this is what people like to look at. So first, when you look at this, anything that says false, I would pretty much completely disregard unless you want to prove something to a patient. But what this is, it's parsing it really as where it is, or you can parse it as to what information you want to be present. So what I would do is I would first sort this by true. And I would say, okay, these are all the true algorithms. What that means is this is accurate for this patient. And then you can decide if you want to curate it or not, so you can remove it or add it.
And by true or false, it means that their data says that this is in play, basically. This is
Correct.
something that they have a risk, or they have a downregulated function, or they have something. So true and false, that can confuse a lot of people. It's not false pathways or false issues. It's just in this patient's data, it suggests that that's not something you need to worry about with them.
Right, is that the literature, the data, this patient's data is not aligned with the algorithm's processes. So if A, then B, then C, well, those, there's either a missing an A or a B in there, therefore C will not be affected. Right. And then again, you can categorize this by category. So if you want to look at anything that's cardiology related, you have all the cardiology here, and now it's parsed by false or true. And I would pay attention to these 4 SNPs, and it says, well, they might have lower HDL levels, or there might be a higher risk of an MI. And, you have to be careful as to what you tell the patient and what you want them to know. If you have a 20-year-old patient, telling them they have a risk of an MI, just be aware of what that might do to that patient's psyche or that mentality. And then again, it tells you whether it's good or bad. And this is kind of to David's point, true or false. It tells you whether the data is there and it's congruent with the algorithm. Good or bad is basically a basic way of saying this is a good thing, this is a bad thing. So,
and once again, on the left, all the way in those check boxes is where you're picking, you're hand picking, basically. You're driving the car stick shift now. Do you want that to be reported on the patient's report or not?
Exactly. And this risk of salt-sensitive hypertension would be a good example as to something you might want to include and say, hey, you have hypertension. It's not because you're having too much salt. Now, I'm not saying you should eat excessive amounts of salt, but perhaps restricting salt will not have an impact on your hypertension. So really good way to utilize the true or false based on what message you want to get across. And then again, the magnitude is based on the amount of data, in vitro, animal, human trials, and then it'll make that equation for you. So you could even parse this by magnitude. What are the ones I want to pay most attention to? Well, we know that there's a significant amount of data on ApoE4, I would not include this because I would say, hey, you don't have the risk for the 2 risk alleles for Alzheimer's, so I might not want to include this. Or the patient does have a family history of Alzheimer's, and you would say, you know what, the odds are in your favor right now, but let's just pay more attention to it. Anything additional here you want to talk about, David, before I move on to the templates?
No, go on ahead.
So again, the syndrome templates are what we see in the reports as well, and in the curation wizard. And you can also include this in your your manual report, the stick shift report, and it'll tell you, do I want to include any one of these maps, which will give an overview as to what SNPs are impacting, neurodegenerative, what SNPs are impacting psychosocial genomics. And again, as it was in the report wizard, it's parsing it by how many SNPs there are, and it'll tell you whether they're homozygous or if they have the risk alleles, if they're heterozygous, or if they have any type of beneficial alleles or SNPs for this particular map. And again, I would probably not include all of these. You can see they removed that. I would only include ones that you find that you think would need to be pertinent or are pertinent to the patient's health. So you can even remove them, and you'll see that now that one is removed.
Yeah, because if you leave all of these there, you're going to get a very, very long client-side report.
Exactly. So I would steer away from these, but also this could be an educational tool for the patient. Say, hey, I want to learn more about phase 2 detoxification or homocysteine genomics. So let me look at homocysteine genomics. Oh, why would I want to look at BHMT? Like, is that important? What is that, right? So you could even click on it, and it'll tell you okay, this is what BHMT is. I get that. And these are the things that are going to be having an impact on it. So really, really intuitive use here and allows you to be a practitioner in real time. And then lastly, the prescriptive tools. Now you can look at pharmacogenomics, the natural products, or the Logos artificial intelligence. So the pharmacogenomics is exactly what we saw in the report wizard, which is kind of self-explanatory, but you could even search it by any particular drug. So you can even type statin, and now it gives you all of the statins. And that'll tell you what the patient's risk allele and what the response will be. So they might have a better response to a rosuvastatin. So it might tell you what does this mean for this patient if they are on a statin. Then you go to natural products, and again, this is going to be what was curated in the report wizard. But again, that was for that particular area. So if you're seeing that curcumin is coming up all the way high here, this does not mean that it wasn't important. It's not important. That's why it was not curated in the report wizard. What this is saying is that for methylation, curcumin is probably not going to be something that is going to have a major impact for you.
Well, another point to make here is if you're not getting specific in category, like a methylation genomics or cardiogenomics or inflammation genomics or detoxigenomics, and you're just running the natural agents across their entire genomic data or their SNP data, oftentimes what you're going to see at the top every time is curcumin, resveratrol, vitamin D, and there's a simple reason why. There's way more research studies in the literature on those things than anything else. There's more data and more studies that have come out in curcumin than any other botanical or maybe natural substance in the last 5 years. So it's always high because there's so much information. It doesn't necessarily mean it would be the most impactful thing in that patient, because maybe the most impactful thing, we don't even know what it is yet, or there's just not a lot of studies on it.
Exactly. And then you could even click on the curcumin and it'll tell you, look at all these genes that it's hitting. It's kind of like the prime example of the one nutrient that can impact multiple different genes. And again, this is where precision medicine comes into play. It's like, do I want to include this? What am I trying to focus on here? And will it have an agonist? And will it have an impact on other things that I might be trying to have an impact on? So it's a really, really good way to be very precise in what you decide. And again, further, the literature here is, you can see how many PubMed hits have been hit. And then lastly, which is also very fun, I think, is the Logos AI. And it'll allow you to it creates a map for you. So you can pick a few different genes. Let's pick MTRR, MAOA, and let's see if we can get just one other one, MTHFR. And you can decide, do I want to upregulate this? So typically you want to upregulate MTRR. Do you want to have a strong effect or a moderate effect? And I'll explain to you what that means as we see it. And then you can do that for each individual one, right? So you want to, if you're having issues with MTHFR or methylation issues, you could upregulate MTRR, you can upregulate the MAOA, and then upregulate MTHFR. And let's pick one that we're going to downregulate. Let's just 1B1, we'll downregulate that. And we'll run the Logos, and it basically maps out for you as, and this is really where I think integrative medicine comes into play, is because we're looking at the whole story and we put puzzle pieces together. And what this is saying is, where do these puzzle pieces interconnect and where do they cross? And you can see here, oh, well, I can move this and see that, vitamin B2 is hitting MAOA and MTHFR. And the larger the circle, the more of an impact that it would have on there. So you can see here, well, if I want to hit both of those, instead of giving 5 different agents, I could just give riboflavin and it'll impact both of those.
So this is basically using a complicated algorithm to do your triaging for you. What's your highest impact intervention, and what's likely to kill multiple birds with one stone, so to speak?
Exactly, and as we discussed in generative medicine and also in the Opus training, where's the hub? Grand Central is the station that you can all roads go to Grand Central, or in Rome, like all roads go to the city center of Rome. Well, let's find those multiple roads that go to that hit multiple city centers, right? And that's what we're trying to pay attention to. And then you would say, well, cytochrome 1b1 really does not have an interaction here. So, I can't hit two birds with one stone if I wanted to have an impact on both of them, but this is where I can.
Well, the report wizard is kind of doing all this in the back end for you. But if you want to drive it in stick shift, as we say, and you want to go through and curate and pick your highest value SNPs or highest value, network maps or whatever, and then you go through this process, you can kind of try to find these things on your own, and you can drill down into much more specific areas and get much more myopic about it. But I think for the vast majority of users, going back to that report wizard, Ralph, maybe if you can click on that, I think most people are going to find that the information they're going to want is falling into one of these categories. Now, once you get used to these different categories, you'll kind of see the subcategories within each major category, so you'll get to know them better. But I think gone are the days where you need to order a methylation report or an estrogenomics report or a detoxigenomics report. Why would you order one of these discrete, very honed down myopic reports with static information when you can just run the whole data set? Like on Genomic Insights, it's always there. You can come back at any time and drill down into each or any category that you like, based on not only how the patient presents today, but how they might come in and present 2 years from now. So it's a living sort of data set that you can work with, manipulate, and extract information from, and you're doing it through an informatics platform that is evolving day by day. So as new literature comes out, as new associations are made in the data sets, it's put into this program. So when you run the data in a category today, if you run it again in that same category 5 years from now, you may get you make it somewhat different recommendations based on what's emerged in the literature between now and then. So it's just a total leap forward in technology and ability for us as clinicians.
Yeah, I think that's probably one of the biggest points, David, that you mentioned, is just this grows as the data grows, the program grows, and it gets smarter, it's more intelligent, and then it allows you to get smarter, and you're on top of the literature. So and then you can trust that this data is backed by research. It's not what Dr. Joe said on a lecture at conference Y in 2012. This is what the literature says, peer reviewed. You can certainly trust it, and it allows it to grow, and not only for the patient but also for you as well. You're just getting this information in real time,
which is really important, because there are some sort of kind of folklore stuff out there in nutrigenomics land where it's, take this if you have this SNP and this SNP, or take this form of this if you have, and when you go look for data supporting it, it doesn't exist. It only exists in somebody's slide deck at a conference, and that's not what this is based on. But some of those genetic genies out there are based on information that is that wobbly, if you will. So that's not what we have here. But the biggest challenge for clinicians is to get used to this new paradigm of practice where we're dealing with such big amounts of information and big data. When you run a chip that has this number, this amount of SNPs on it, for instance, you can't just get it in a static report on a PDF, or you're just looking at a very, very small part of the meaningful data. So what we're doing is changing the paradigm. Now your lab results are being delivered through smart, active portals that can curate it and make sense of it, and can parse it in a way that a human brain can't do. It's much different than getting the PDF from the lab. It's the game is changing, and we're either going to change with it, or the people who come trained behind us, like you were, Ralph, and you were, Dr. Boyd, are going to just leave us all in the dust. So hopefully this kind of construct in Genomic Insights with Opus23 Explorer helps us all get there. And I wanted to thank you, Ralph, for giving such an expert overview of the program. We only scratched the surface, but I think it gives people a little bit of an idea. They need to basically go in and play with it. They can even run their own data set first if they're more comfortable, and then go in and play with the various categories and kind of learn about their own genomics before they even use it on a patient if they wish. So I wanted to thank you for being on, and Jeff Ingersoll, I'll send it back to you for our wrap.
Thank you both. I think that was an outstanding overview and certainly necessary. And I just think that it brings a lot of value. So just thanks to everybody that was here. And Ralph, again, thank you for talking us through that. And Dr. Brady for guiding us. The last points that you made were just very powerful points about just the evolving nature of it. So thank you both. Look forward to having you guys back again.
Thank you.
Thanks so much.